so much. Thanks to Dr. Langer for inviting me to speak today. And actually, Corey, I think that was about a drug, wasn't it a drug-addicted teen in that movie? Anyway, that's not me.
Matter of fact, and the cancer is drug-addicted. So
that's true, there you go. Okay, so as you heard from Corey, I'll be focusing mostly on ALK today, but also talking about a related molecular subset, that is those cancers that have a rearrangement of ROS-1. And as all of you know, here is our sort of typical pie chart summarizing the different oncogenic drivers in non-small cell lung cancer. And ALK is in about 5% or so of our patients, ROS1 in about 1%. So relatively small subsets. But as many of you know, these patients do really well now with all the targeted therapies we have. And so they often will actually live very long and do very, very well. So it's really important to understand how to treat these patients. So we're going to focus on ALK. And this slide actually summarizes basically 10 years worth of data in terms of where we currently are, I should say up until about a month ago, where we've been in the ALK world. And that really has focused on the use of ALK inhibitors sequentially in our patients who have metastatic or advanced ALK-positive lung cancer. And so over the last decade, we've established that the first-generation ALK inhibitor, Crizotinib, is a standard first-line therapy for patients with newly diagnosed disease. And then since those studies were done, we have also had numerous new next-generation ALK inhibitors developed, and at least 3 of those, so-called second-generation inhibitors, Ceritinib, Alectinib, and Brigatinib, are now approved therapies, standard therapies for our patients who fail on Crizotinib. However, as you know, this paradigm of sequential first and second generation ALK inhibitors is changing, and it really has happened in just the last few months. And really the question is, what is our best first-line therapy for our ALK-positive patients? Is it really Crizotinib? And that was the point of the audience response question that Corey read. So let's focus on this question first, which is the best first-line therapy for our patients. And as you know, there are a number of different options, and I've listed them here. Standard chemotherapy, the first-generation inhibitor Crizotinib, and then the second-generation inhibitors Ceritinib and Alectinib. So I want to start by just reviewing the data we have in the first-line setting. And as you know, the very first data that we had was comparing Crizotinib with standard chemotherapy, and that was done in the Profile 1014 study, which was published by Ben Solomon in the New England Journal of Medicine. And shown here is the study design where newly diagnosed patients with ALK-positive lung cancer are randomized to either first-line Crizotinib or first-line platinum pemetrexed, 4 to 6 cycles with no maintenance, and the primary endpoint was PFS. And as expected, Crizotinib, the targeted therapy, was superior to chemotherapy. Here, just to note, the median PFS with frontline Crizotinib was about 11 months, whereas the median PFS with platinum pemetrexed chemotherapy was 7 months, so hazard ratio of 0.45. This led to the widespread adoption of Crizotinib as the standard first-line therapy. However, since then, we've now had several other important randomized trials to be aware of. The next one that was done was a study of a second-generation inhibitor, Ceritinib, now also compared to chemotherapy, not compared to Crizotinib, but compared to chemotherapy. And this was the ASCEND-4 trial. So another first-line trial of patients with advanced ALK-positive lung cancer, here randomized to a first-line targeted therapy of Ceritinib or to receive platinum pemetrexed, and this time also with maintenance as well. Again, primary endpoint was progression-free survival, and again, not surprisingly, we see this in every trial that we do of targeted therapies versus chemo in the patient population with the target. Ceritinib was very superior to platinum chemotherapy. As you can see here, median PFS with frontline Ceritinib, a more potent ALK inhibitor than Crizotinib, was almost 17 months, and with chemotherapy, frontline chemotherapy, kind of as expected, the median PFS here was only 8 months. So again, a hazard ratio of 0.55. TKIs are absolutely superior to chemotherapy as first-line treatments. Just to point out, though, as many of you know, Crizotinib is a very potent ALK inhibitor, but unfortunately it is accompanied by a number of significant side effects, particularly GI side effects. This is using Crizotinib at the standard dose of 750 milligrams once a day. And just to highlight how common the GI side effects are in these patients, with the vast majority of patients experiencing nausea, vomiting, diarrhea. And this has really limited, I think, the uptake of Crizotinib. Now, fortunately, we have very recently 2 randomized studies now comparing for the first time a second-generation inhibitor with the standard therapy, that being the Crizotinib. This is now 2 trials of alectinib versus Crizotinib. The first one that was presented was the ALK study. This is the Japanese randomized study of ALK-positive patients to either not first line, but these were all Crizotinib-Naive, so their first TKI was either alectinib or Crizotinib. And here, just to note, in the Japanese population, the standard dose that has been established from the prior studies was 300 milligrams twice a day, but that is only in Japan. Primary endpoint of PFS. And this was shown at ASCO 2 ASCOs ago in 2016, that alectinib was superior to Crizotinib as the first ALK TKI for patients with ALK-positive lung cancer. The median at the time was not reached for alectinib, but with Crizotinib, it was as expected at about 10 months, and hazard ratio of 0.34. Now, since then, we've now actually completed and reported on the global version of the ALK study. This is what we refer to as global ALK. We presented this at ASCO, and it was recently published in the New England Journal. And it was a similar study as the ALK study, except that these were all newly diagnosed patients with advanced ALK-positive lung cancer. And here they were randomized either to the standard dose of alectinib at 600 milligrams twice a day, or to Crizotinib at its standard dose. And this, just to note, there's no crossover in these protocols. Primary endpoint, again, of PFS. This is the primary endpoint of PFS by investigator, consistent with ALK's very positive study in favor of alectinib as first-line therapy. Here again, the median PFS with alectinib had not been reached at the time of the data cut, but with Crizotinib, it was 11 months. Hazard ratio came in at 0.47. One of the secondary endpoints was PFS as assessed by independent review, and here we actually did have a median PFS with first-line alectinib, and that was actually close to 26 months, again, compared to about 10 months with first-line Crizotinib, hazard ratio of 0.50. So really pretty remarkably prolonged PFS when we use a more potent second-generation inhibitor as our first-line therapy. As expected, the PFS benefit was very robust. It was seen across essentially all of the subgroups that we looked at. And just to highlight those patients with and without brain metastases, the benefit of alectinib was clear in both of those subsets. Alectinib is known to be highly brain penetrable. And we did further analyses of the CNS activity of alectinib versus Crizotinib in the global ALK study. Here's one of our secondary endpoints, which was time to CNS progression. And we did this as a competing risk analysis to take into account the competing risks of non-CNS progression and death. And what you can see is that alectinib significantly delayed the time to CNS progression. Here, the hazard ratio was 0.16, corresponding to an 84% reduction in the risk of developing CNS progression as the first site of progression when patients were treated with alectinib compared to Crizotinib. And on the right-hand side are the cumulative incidence rates of CNS metastases and those patients randomized to receive either alectinib or Crizotinib. At 12 months, you can see that the cumulative incidence rate of patients treated with alectinib was 9%, and that was compared to 41% of the patients treated with Crizotinib who had CNS as their first site of progression. So again, consistent with the CNS activity of alectinib, we saw significantly higher responses in CNS metastases when patients were treated with alectinib compared to Crizotinib. The response rate here, if you just look on the table showing measurable CNS lesions at baseline, the response rate was about 80% versus 50% with Crizotinib. And significantly, you can see that the median duration of response was much, much longer with alectinib as expected. The median duration of intracranial response was about 17 months versus about 6 months with Crizotinib. And so now I would say, taking all of those studies into consideration, that second-generation ALK TKIs have really become the new first-line standard of care. And in fact, both Crizotinib and Alectinib are approved in the first-line setting for ALK-positive patients. Here I've summarized all the data we have for Crizotinib, Crizotinib, and Alectinib as the first ALK TKI for patients with advanced ALK-positive lung cancer. Obviously, we're doing some cross-trial comparisons here, but I think it's very notable to see the data from the ALEX studies are very, very consistent. What I've shown here is data from the J-ALEX study that was recently updated. So now the median follow-up for both of the ALEX studies is quite long, at over or about 20 months. And you can see that the median PFS with frontline alectinib comes in at about 26 months in both of those studies, and extremely high response rates as well. So now I think it's pretty well established that alectinib is our new first-line therapy for ALK-positive patients, but really I think a bigger problem that's emerging, of course, is resistance to second-generation inhibitors, whether or not they've been given in the second-line setting or given as first-line therapy. And so much of our research has focused on identifying mechanisms of resistance to second-generation inhibitors like alectinib. And so what are our treatment options for those patients? Well, this is a large study of repeat biopsies that Justin Gaynor at our hospital undertook, and there was over 100 biopsies from ALK-positive patients who had failed on first or different second-generation ALK inhibitors. And what we've summarized here is the proportion of those resistant patients who developed specific ALK resistance mutations, and those are all color-coded here. And I think as what you can see right off from comparing these pie charts is that we see more ALK mutations emerge in patients when they fail these more potent ALK inhibitors like Crizotinib, Alectinib, and Brigatinib. And each of these second-generation inhibitors, they each have different chemical structures, although they're all potent inhibitors of ALK, but they make different contacts with the ALK tyrosine kinase domain, and because of that, slightly different resistance mutations can predominate at the time of resistance. So the profiles are slightly different for Crizotinib versus Alectinib versus Brigatinib, although you can see by the red slice of the pie that one particular mutation is quite common after all of the second-generation inhibitors, and that's what we call the solvent front mutation, ALK G1202R. So we've done a lot of data, a lot of studies in the lab to characterize these different mutations and the activities of all of these different ALK inhibitors against the different mutations. And just to look at this chart at a high level, what we're summarizing here is the potency of different first, second, and now a third-generation inhibitor, Lorlatinib, against all of the known resistance mutations shown on the left. And we've color-coded potency by, in terms of how potent they are. So green indicates high potency, red indicates much less potency, and yellow is sort of intermediate potency. And I think what you can appreciate looking down each of the columns is that each of the ALK inhibitors does have a slightly different activity profile against these different resistance mutations. And as I pointed out earlier, that G1202R mutation is important for us to know about. It does cause resistance to first and second generation inhibitors, but fortunately not to our third generation inhibitor, Lorlatinib. So now what do we make of all of this data? Well, I think the reason this helps us in the clinic is because we have these patients who are failing on second-generation inhibitors, and what are our treatment options for those patients? Well, I would argue that if we can understand those patients' resistance mechanism, then in some cases we can actually tailor our selection of next-line therapies based on the resistance mutation that's emerged. So as an example, I1171 is a very common mutation emerging after alectinib, and actually Crizotinib has activity against this mutation. We now have seen clinical activity of Crizotinib after alectinib in this specific setting. And I've given a couple other examples here, and you'll have copies of these slides of how we can match second-generation inhibitors to specific mutations that we predict they should overcome. But as I mentioned, we have a third-generation inhibitor now. It actually is, we sometimes refer to it as Pan-Inhibitory because it does have activity against all of these single ALK resistance mutations, including ALK G1202R. This is the drug. It's now called Lorlatinib, not that long name there. But this is just some early data that was done to characterize the activity of this new drug. It's highly CNS penetrant. It was developed to be very CNS penetrable, and it was designed to overcome all of these resistance mutations. We now have published data on the phase 1 experience with Lorlatinib. This just came out last month. And this is a waterfall plot summarizing the tumor responses in ALK-positive patients who enrolled in the phase 1 study of Lorlatinib. And what I've written here above each of the bars is the number of prior ALK inhibitors these patients received. And you can see that by and large, many of these patients had actually failed 2 or 3 previous ALK inhibitors. And you can see by all the downward bars that many of those patients were still responsive to yet another ALK inhibitor, that being Lorlatinib. You can see that actually response rate turned out to be about 40 to 45% for patients who had failed 2 or more ALK inhibitors, and the median PFS was about 9 months. At ESMO, Dr. Philippe presented additional data now from the phase 2 portion of the Lorlatinib study, and she specifically looked at the activity of Lorlatinib after a number of different second-generation inhibitors, as shown here. And you can see the response rate is coming in at between 35 and 45%, again, after failure of a second-generation inhibitor. And the intracranial responses were even higher than what we saw systemically, with intracranial responses coming in at about 45%, even after patients had already failed on the brain-penetrant agent alectinib. We also showed in the phase 1 study and also in the phase 2 that Lorlatinib does seem to have its best activity in patients whose tumors have resistance mutations, including G1202R. So shown on the left is the waterfall plot of a group of patients who had failed 2 or more ALK inhibitors. We had biopsied those patients and identified resistance mutations in some of them. And then shown on the right is the duration of treatment for those patients. And you can see that those patients who had ALK resistance mutations were really highly sensitive to Lorlatinib, and their responses were quite durable. Some of those are actually now exceeding 3 years. And again, after failure of 2 or more ALK inhibitors. So now I think our current treatment paradigm has been evolving. Many of our patients will now be treated with first, second, and third generation ALK inhibitors. And again, now we're starting our newly diagnosed patients on alectinib, in some cases Crizotinib, but even then I think there still will be a role for sequential treatment with these ALK inhibitors, since Lorlatinib has activity after failure of these second generation inhibitors. So in the last 3 minutes, let's just focus on ROS-1. So as I mentioned, ROS-1 is a related target. It's distinct from ALK, but it can be activated by chromosomal rearrangements just like ALK. And remarkably enough, Crizotinib turns out to inhibit both ALK and ROS-1 extremely well. And so now Crizotinib is a standard therapy for advanced ROS1 rearranged lung cancer, and that came about from a number of studies, but particularly the phase 1 study of Crizotinib, the Profile 1001 study. And in that study, we had about 50 patients with advanced ROS1 positive lung cancer and saw a response rate of 70% with Crizotinib and a median progression-free survival of over 19 months. So Crizotinib is a highly, highly active drug for ROS1 as well as ALK. There have also been subsequent studies of Crizotinib in ROS1 patients, which I've summarized here. And the main one I want to highlight is the study on the far right, which is the Oxford Oncology study. That was ROS1 positive patients in Asia who were treated with Crizotinib. It's the largest study of ROS1 that we have to date, and that was 127 ROS1 patients. And the response rate was consistent with our previous study at 72%, and again, a pretty remarkably prolonged median PFS coming in at about 16 months. We actually do now also have data on next-generation ROS1 inhibitors in Crizotinib-Naive patients, so getting at the question of what is our best ROS1 therapy. I've shown here the data for Profile 1001 just as a comparison, and next to that I've shown the data that we now have for Crizotinib in patients with ROS1 positive lung cancer, as well as Entrectinib. So both Crizotinib and Entrectinib hit both ALK and ROS1. And they had relatively small phase 2 studies that were recently either published or presented. And you can see that both Crizotinib and Entrectinib are also very active in ROS1. And I would point out that Entrectinib in particular, which is known to be very brain penetrable, actually is now coming in at a median PFS of 29 or close to 30 months in patients with advanced ROS1 positive lung cancer. So an impressively long response in these patients. Are very, very sensitive to ROS1 inhibition. But what do we do for our patients who fail on their first ROS1 inhibitor? Well, we know a lot from the setting of patients who have failed Crizotinib. We know that the most common ROS1 resistance mutation emerging is ROS G2032R, which actually is analogous to the ALK G1202R mutation. You can see here in our institutional experience that almost half of our patients who fail on Crizotinib have this G2032R mutation. It's kind of like the T790M equivalent in EGFR. And so what's been really important is to hopefully be able to develop next generation ROS1 inhibitors that can actually overcome G2032R. So I've listed these ROS1 inhibitors, and what I've highlighted here is whether or not they can overcome this G2032R mutation. And note that Crizotinib and Entrectinib cannot. They actually have no activity against G2032R, but several of the other drugs do, including the bottom drug TPX-0005, as well as a few others. I do want to point out data with Lorlatinib. Again, Lorlatinib is a third-generation ALK inhibitor, but also a very, very potent ROS1 inhibitor. And we do now have data on Lorlatinib in ROS1-positive patients. This was presented by Ben Solomon at World Lung last month, and shown here is a mix of ROS1-positive patients. Some had already failed Crizotinib, some were Crizotinib-Naive. The ones that are asterisked in the overall waterfall plot are the ones who previously received Crizotinib. So again, you can see that a lot of these patients retain sensitivity to more potent ROS1 inhibitors. And again, we're also seeing really phenomenal CNS responses with Lorlatinib in these ROS1 positive patients as well. So to summarize, ALK and ROS1 positive lung cancers are distinct molecular subsets of lung cancer, and they're both very oncogene addicted. Alectinib has become the new standard first-line treatment for patients with advanced ALK-positive lung cancer. Alectinib-resistant tumors, and I would say other tumors resistant to second-generation inhibitors, they may still respond to another next-generation inhibitor like Lorlatinib, particularly if they have ALK resistance mutations. ROS1 positive lung cancer is also highly responsive to TKIs, but we are still working on establishing the optimal first and second line therapies for our patients with ROS1. And finally, rebiopsies at the time of resistance, I think they can really help us in picking subsequent targeted therapies that are most likely to be effective for our patients. Thank you very much.